doing this, and then they've learned over time that this is part of their payback for maybe doing something the day before.
I think you do mention in your statement that one of the concerns you have is about the nomenclature of fatigue. Somebody describing what somebody has who has long COVID as having fatigue, almost to the extent that that expression tends to diminish its significance.
Yeah, it's very difficult, the word fatigue, because it may be taken to mean being tired, but it isn't the same tiredness that people get because they've had a busy day. It's this person might wake up as if they haven't been to sleep. And I've heard it described as, as if you've not slept for a week and just woken up. So I think the term fatigue is a difficult one, although there isn't really another one to put in its place. But in this context, it doesn't mean tiredness.
Now, the point you make on that is at paragraph 89 of your statement. This is where you're dealing with issues that are difficult to treat, but I think you make the point that fatigue is a terrible word for this condition.
Yeah.
And you believe deliberately used to make it seem less serious.
Yeah, if you look, we have to look back the history of ME CFS to see why the term kept changing. So it started out as ME, and then it was replaced by chronic fatigue syndrome, and then later on there's been lots of campaigns over the years. Now, most people would use the term ME/CFS, but chronic fatigue syndrome on its own, there is a history of why that happened. And going back into the 1990s, early 2000s, and certainly it appears to be that it was to make it seem like it wasn't a disease that might stop you from being able to work, for example.
And I think, again, in this context, you do express the view at paragraph 90 of your statement that you believe most patients have got inflammation at some level in their brain, and the fatigue part, it's not tired, it's an actual inability to meet the set amount of energy required for daily activities as a human. Now, can you explain what you're saying there and how that can be tested?
So there have been tests done on inflammation in the brain, many research papers, and the tests that we use in clinical practice, such as MRI scanning, will not usually show this up. But there was a study done by a private group in America who looked at PET scanning, and they also looked at the blood vessels in the brain. And they found that in the long COVID patients, in about a quarter of them, that they had inflammation in multiple areas of the brain that do multiple functions. There have been studies that look at the population, and since COVID, following up these patients who were just in the UK Biobank, it's a biobank of patients, a drop in IQ, there's been grey matter loss. We know that COVID can infect neurons. So I think if we extrapolate what we know from these studies, although we can't currently put that person through a scanner, we know from the research that they do have inflammation in research study.
Right. And I move on to cognitive dysfunction. Now, I'll probably confuse matters by talking about putting a pan on a cooker, and that's more cognitive dysfunction than post-exertional malaise, but or in my case, probably disinclination.
To be fair, if you've got post-exertional malaise, you're more likely to leave the pan on the cooker.
Yeah. The cognitive dysfunction, how does that manifest itself in the patients that you're seeing?
Many of my patients have to bring notes to appointments, write everything down, so they can't actually remember their own medical history. They will tell me about how they are trying to function and they can't find the words they're looking for, so they'll word search, they'll give the wrong words for things, I would say that even just watching a patient, if you're on video, you might notice at the start of the call they're talking normally, and by the end their face has just dropped and they just can't remember, and they get really frustrated because their brain just isn't firing properly.
And is there a treatment for that?
There isn't a treatment for inflammation in the brain as such in long COVID, but there are medications that help to reduce inflammation. And in some patients, simple things like antihistamines have helped with those symptoms.
You say at paragraph 92 in relation to cognitive issues, they're very hard to treat. And you make reference to the use of referral to a neuropsychologist, do detailed assessments, but there are long waiting lists, so most people haven't seen them even after 4 years.
Yeah, and that's to characterise which bits of their function they've lost, because they might have a responsible job where they may need to have that function to do their job, for example. Most people haven't had that done. The other way you can sometimes treat cognitive issues is by treating their POTS, because they're talking about blood going to the brain. Blood's not going to your brain. You're not getting enough oxygen to your brain. You're not getting enough nutrients to your brain. That's another way of doing it. But if we have virus still in the brain and we don't know yet what we're dealing with here, how do you treat that? And that we don't have answers to those sort of questions still. And detailing what patients have with a neuropsychologist at least allows them to, for example, if they need benefits or work adjustments, to say these are the bits that I can't do. And currently all they have is what they can tell people is that they can't order their work, or they can't remember to take the pot off the cooker.
You make an interesting point at paragraph 92 that some people who have cognitive issues may be reluctant to admit to them.
Yeah, I mean, if you think about people's livelihoods, and they may not be able to do their job if they've got cognitive issues, so it ties in with with livelihood and being able to support people supporting their families.
It may be useful to talk about some of the examples of extreme fatigue that you've encountered, and perhaps we can do this under reference to that section of your statement under the heading bedbound patients.
Okay.
Now, you've, I think, already mentioned that there are patients, and you put it by saying they may be of all ages, who cannot tolerate any noise or light, and need a commode for the toilet, need to have tubes for feeding, and the carers come to you to obtain advice, I suppose. So within the cohort of your patients, how many people fall into that sort of category, that they can't tolerate noise or light?
There's many that have light and noise sensitivity, but the ones that are bedbound and not able to tolerate it at all is probably about a quarter of what I see. So it's not the majority, but there is I probably see more than anyone else of these unfortunate people who can't tolerate it at all. But a lot of long COVID patients will have light and noise sensitivity as part of their illness, but not need to be in a darkened room as such. But these people, I would say probably about a quarter.
You describe it in paragraph 66 as a living hell for a lot of those patients.
Yeah.
Is that?
I don't know how they bear it. especially when they don't have very much support or input. I don't know how their carers bear it, because it's not just a few weeks, it's not just a few months, it's years and years, and they don't know if they're going to get better.
You do give one specific example, which I think perhaps brings out some of the extremity, perhaps, of the difficulty for people with this condition and for their carers in paragraph 69. And you talk about situations where people may have parents in their 70s or 80s and are dealing with adult children who are have long COVID to the extent of being bedbound. And you give the example that those parents may have to hold bags to the bed so that the patient can defecate into the bag. Is that something that is something you've come across?
I have a number of situations of what were independent adults who were working, had their own house, have had to move back with their parents, who are elderly because they lost their job with long COVID. Their conditions got worse. They haven't had any help, and resulted in these sorts of situations where they are too unwell to get up from the bed, and their parents do have to help them go to the toilet in the bed. And I've seen some of these people. I don't often speak to these patients because they're too unwell to speak to me, but their parents, who are doing this often in their 70s, sometimes in their 80s, are completely broken doing that.
Can I ask a question which, at one level, is extremely simplistic? You said earlier on in your evidence that many patients consult you either face-to-face or online. They've been heard about you by word of mouth. They have perhaps, I think in fact you said, they've seen general practitioners who have either sent them to a specialist of an inappropriate speciality or have declined to refer them to a specialist. Now, I can understand that all makes sense. But what you're describing in paragraph 69 is people who've got really very extreme symptoms on any view. And I would have thought, this is the simplistic part of my question, I would have thought people with symptoms as extreme as that would have been seen, not only by GPs, frankly, but would have been referred to, and of course I don't know what the appropriate speciality would be, but an appropriate speciality, or a speciality who would at least willingly look at them.
What often happens is that they get unwell very quickly, and then they can't get to those appointments, and there aren't teams that go out to see them. So it might be that they should see neurology, for example, but how do they get there? How do they get the scans when they can't stand any light and sound? So they can, if they have a gradual decline, they might have seen the specialties, but if they've very quickly declined, there isn't a service that takes them.
I understand that, but if someone had symptoms as extreme as that, particularly I would have thought if they came on suddenly, can either themselves or whoever's with them phone 999, frankly.
So often they will have presented over and over again to A&E with their symptoms, and I've said elsewhere in the statement that they might be told they've got anxiety, that that's the problem. It's not, they can't possibly be this ill. And I think there's a lack of understanding in medicine about how unwell people can be. You could admit somebody to hospital for investigation, and some of these patients have. However, many are concerned that they'll get worse being in a hospital environment because they're going to need a side room. They can't stand the noise. The noise to these people is excruciating. Their brains are so sensitive. So they might be in a position where even if they were offered, you could go to hospital for a week and have a number of tests, that they wouldn't want to go because it would be too painful.
Yeah. Sorry, Mr. Keogh.
Thank you, Mother.
Thank you.
I'd like to ask you a little bit about your patients and just to be clear, please don't mention any names.
Of course.
You wouldn't
No,
in relation to confidentiality, but please don't. Just in relation to your patients, you say at paragraph 48 that your patients don't come to you with one symptom. They're coming with a full package of symptoms. Is that the standard presentation to you?
Yes, so you can define long COVID as persistent symptoms after a few months, but what I see isn't one symptom, it's everything. The fatigue, the post-exertional malaise, the headaches, all of it. It seems to be if you get one of these things, you tend to get more than one thing.
Yeah. And in paragraph 50, you say that the story invariably starts with the situation pre-COVID. And you give a quote, I was well, doing lots of exercise, working in a job full time, and then I got COVID, and then I didn't get better.
Mostly that's what I hear. I've heard it hundreds of times over, the same opening sort of statement of what's happened to them.
And so far as pre-existing conditions are concerned, I think one of the things we've heard is that certainly in some of the comments that have been made about those people with long COVID is that, oh, well, you must have something wrong with you. And this is why COVID has exacerbated your condition. What do you respond to that?
Certainly in my clinic, that's not what I see. I see people who generally haven't been on any medications or had any health problems. Maybe they might have had a bit of mild asthma or hay fever, but it's certainly not what I see in my practice is people who have had pre-existing conditions that COVID has made worse. Of course, it is possible to have a pre-existing condition that COVID makes worse, but the actual, as you say, package of long COVID, the multi-system, the people I tend to see were people who were well beforehand and didn't really know that this could happen to them with COVID because they were told it was mild and they were unlikely to be hospitalised or die. And I'm not sure that most of these people realised that this could happen to them because they were previously well.
Mental health is an issue I'd like to ask about. Paragraph 51, you say very few of your patients have any previous mental health issues or are on any medication when they come to you. And you then develop this at paragraph 127 of your statement, and you say, I genuinely don't think most of them have any deep mental health issues, but I think they have a fear of being told that they are mentally ill as the cause of the illness.
Yeah.
So probably two different perspectives there. One is patients coming to you with long COVID, and they generally, as I understand what you're saying, are not patients who come with previous mental health issues.
Most of the time, no. I always explore how people are coping with their illness, given it's a multi-system illness. And they generally haven't had any previous mental health issues. And often when they've went to their doctor to say they've had COVID, they've not got better, they've got X, Y, and Z symptoms, are told, well, it's anxiety. And they will sometimes be diagnosed with anxiety when they don't have anxiety, they have POTS, for example. As time goes on, I think the illness gets harder to deal with. Patients who have been unwell for 4 years, coping with that. And I think that it would be natural in that position to, struggle with motivation or how your moods and how you're feeling when you've got a disease that people don't understand and there's no help for. But generally, what comes to me is people who are working, had lots of activities, social life, and weren't mentally ill. But they do often get then told they have a mental illness instead of long COVID. Eventually, when they don't get better from that, then they get a diagnosis of long COVID.
Right. Just in terms of the gender of your patients, you tell us at paragraph 54, and Mrs. Ormerod has already made this point this morning, that this is a condition that appears to predominantly affect women.
Yeah, so any of these diseases that are what we would say inflammatory, so the immune system overreacting, are more common in women. And we know that when people are pregnant, that they may well get a relief from their symptoms, for example, in conditions such as lupus. So we know that there is an effect of hormones on these types of diseases, and we know that women are more likely to get these types of diseases because of their partly because of their hormones, but also because of their gender. That there is something about women that is more likely to have an autoimmune / inflammatory type disease.
Right. I think you also say that with the skepticism that may exist in relation to long COVID, there may be another element to that, which is misogyny.
Yeah.
Is that something you've come across?
It is. I've had patients tell me things that have been said to them by members of the medical profession, and I do think some of it is misogyny, being told to that it's because they're a female, because of their age, that they've got this imaginary illness, and often the people that do this don't try to hide it from the patient. They're very frank with them, and there's a lot of patients who I will see them and something that's been said to them maybe 4 years ago, it's still stuck with them, that I was told this by this particular, such as, you know, you're this age, you've just put on a bit of weight, you just need to go and do some exercising, and you're, you know, I see a lot of, they'll be told that they see a lot of women like this in this age group. Yeah.
You also indicate at paragraph 57 that in terms of age, most of your patients are between 20 and 50. So that puts them into the working category, I suppose. And clearly, and we heard a good deal from Mrs. Ormerod, and one of the documents that she's provided to the inquiry about the effects that has on the ability to work and the necessity to have employers who are sympathetic towards the condition that somebody has.
Yeah, it just hits right in the working age group.
Yeah.
And employers will be mixed in their response. There's some very good employers who are still employing their their employees, my patients, with reduced hours, for example, but there are other ones who have lost their jobs, and some people are only, you know, a couple of weeks of income to homelessness. You know, not everybody's got savings or a backup. Not everybody's got income protection. Most people probably don't. And they are hanging on by a thread, some of them, to their livelihood for their children. The study in doctors, 1 in 5 doctors with long COVID can't work. And there's lots of headlines recently about the increase in people who are not able to look for work. So if you follow the pandemic from 2020 and the numbers of people not working, it does correlate with the increase in long COVID. Obviously, there's other reasons why people don't work, but I think because it's so prevalent in that age group, that it has a huge impact on employment. There will be elderly people with long COVID who never get diagnosed with it, because they will potentially get more forgetful, decline. I've seen it in my own patients in general practice, decline, and it looks like old age, but actually they've had COVID and never got better from that COVID. So they're probably not diagnosed. And what's interesting about long COVID is that with ME, you don't tend to get as many people up to about 50. It tends to hit people younger in life, sort of teenage years in their 20s. And with long COVID, it seems to affect a whole spectrum up to an older age than what I see with ME. But I suspect there's many not diagnosed in either side of those groups.
I just remind you, you've got 15 minutes left, Mrs.
Yes, thank you, Melodious. Just if I can take children and teenagers briefly. As we've established, you don't see patients under the age of 16, but obviously you do see patients who have had long COVID as a child and then graduated, as it were, to seeing you. And you do tell us that paragraph 58, there's a lot of children that are told it's in their head, but they may have been in bed for a few years before you see them.
In bed, yeah, absolutely. And I've managed to give them peak treatment for POTS, got them out of bed, and got them back to some education or something that resembles a normal life.
And so far as recovery is concerned, I think you do indicate at paragraph 102 and following that teenagers make the quickest recovery.
Yeah.
Can you identify a reason for that?
I don't know if it's to do with their physiology. So our bodies change as we get older, our immune systems change. But the most dramatic recoveries I've seen are teenagers who I have treated for POTS and dampened down their immune response, and they've had extraordinary recoveries. And they may have had no treatment for several years, and it seems such a waste that treatment couldn't be instigated by any doctor several years before and to save the suffering that they've had for those several years.
Briefly, you do and have produced for us a paper from the Lancet on outpatient treatment of COVID-19 and incidence of post-COVID-19 condition over 10 months. And reading very short from that, because we can look at it in detail. This was something that was produced in October last year. And the interpretation of the trial that was carried out was that outpatient treatment with metformin, which I think we all know is a drug normally associated with the treatment of diabetes, this reduced long COVID incidence by about 41%, with an absolute reduction of 4 to 1% compared with placebo. Metformin has clinical benefits when used as outpatient treatment for COVID-19 and is globally available, low cost and safe. Is metformin something you prescribe for some of your long COVID patients?
So this is more looking at prevention of long COVID. But at the moment, and it's been the same for the past 4 years, that we have a reactive style of responding to COVID. So if somebody gets COVID, it's essentially, in the beginning we're told wait until you're blue and then go to hospital. And still we don't have much treatment at the time of COVID. So if you get COVID and there's a drug here that may, probably needs some more work, but may reduce your risk of long COVID by nearly half, 50%, would that be something you might want to take? And at the moment, and there's going to be other drugs like that already exist, so that's why we do research studies. A very small percent of the population can have antivirals. They also reduce down the risk of long COVID. So what we're doing is we're letting people get long COVID, and then we're not treating it once they've got it when there is potentially preventable medication for them.
Okay. I can bring your evidence to a close, Doctor. You've provided us with a section on what we need, and I think in our discussions, I think we've probably identified that most of these elements come with a cost in financial terms. But one of those that I do want to ask you about is what you say at paragraphs 143 and 144. And perhaps you just read those out, please.
Most of all, we need to stop telling people that it's psychological, because we have enough research to know it's a physiological illness. Education is important, so we need to stop telling people with long COVID that they need to just try harder or exercise to get better, because that is adding to stress on top of what they're already going through.
Dr. Taylor, thank you very much. Is there anything further that you would like to is there anything further that you would like to talk to us about?
I think I would just like to add that the risk of long COVID is still there, and the recent Canadian study suggested that by 3 infections, your risk of long COVID is 38%. What we don't want is a population full of people who are unwell like this, who are suffering, who can't work, who are losing their houses, and not aware that that risk is still there. So I think we need to do more work, and this especially applies to children, in schools, for example, of ventilating buildings to a standard whereby COVID is taken out of the air. We need to have people who are, obviously unwell with it, not attending school. The prevention of long COVID is really important, and I think the reporting of long COVID and the reporting of COVID, we should remember that it is still a dangerous virus, and although it's not killing people in the same numbers that it did before, it is primarily disabling people. And I think it's just worth that we are still aware of that, and there's a lot of work to be done aside from fixing patients that are already unwell to prevent more cases.
There's one point, I'm sorry, I should have asked you. It relates to a matter I discussed briefly with Mrs. Ormerod this morning.
Yeah.
We've heard from a number of both representatives and witnesses that post-viral syndrome of some description